So the consensus point 2 is how early can we start ARNI acute decompensated heart failure? Should we start pre-discharge or at first follow-up? And then what are the precautions? So very landmark trial was Pioneer Heart Failure. That was a study design of hospitalized patient with ADHF, that is acute decompensated heart failure, with LV of 40%. Total number was 888 and 881 number of patients. They were stabilized while still hospitalized with systolic blood pressure more than 100 millimeter mercury, and prior 6 hours with no symptoms, no increase in IV diuretics in prior 6 hours, no IV vasodilators, and no IV enalapril. So they were basic 4 criteria: the stable blood pressure, no need of IV diuretics or vasodilators in preceding 6 hours, and no IV enalapril in preceding 24 hours. If they were the patient with heart failure with the EF of less than 40%, then let's start this combination of sacubitril valsartan. As Indian scenario, sometimes we start with 50 milligram twice a day, then gradually jack up. The standard dose, yes, is 100 milligram, then go to 200 milligram. But we can start 50 milligram twice a day, then after 2 weeks, 100 milligram. The idea is that to start maximum tolerable dose, that is one. And we must start ARNI. Some ARNI is better than no ARNI. So start this molecule, gradually increase the dose. So in hospital initiation was there, blinded study for 8 weeks was there, and the evaluation point was NT-proBNP, safety and tolerability, and clinical outcomes. And it was compared with enalapril 10 milligram twice a day. So what was the outcome? Among patients with HF hospitalized for ADHF, the in-hospital initiation of sacubitril valsartan led to a greater reduction in NT-proBNP and improved clinical outcomes compared with enalapril. So this is the change in NT-proBNP from baseline and after 8 weeks in this group, and CV deaths or hospitalization for heart failure in this. You can see a huge difference between the two molecules. So if you have the breakdown of the patients, then de novo heart failure was, you can see almost 7%. De novo heart failure with ACE inhibitors in ARB, no, was almost, you can say, 27%. Worsening chronic heart failure on ACE inhibitors and ARB, yes, was, you can see, almost 41%. And worsening chronic heart failure with no ACE inhibitors in ARBs was almost 21.8%. And you can, there is a good change in NT-proBNP after 8 weeks based on the prior history of heart failure and treatment status as per admissions. A great reduction of NT-proBNP if you compare with the ARNI as well as enalapril. So such improvement in early clinical outcome would be lost in a scenario of ACE inhibitors ARB pre-treatment. That is what is the ACC 2021 writing committee has recommended. So if you look at pioneer heart failure outcome in patients without prior ACE inhibitors ARBs, outcome similar regardless of prior. So whether the patient was on ACE inhibitor ARBs or not did not matter, but patient must be on ARNI before discharge.